Good afternoon to everyone. It's a great pleasure for me to introduce the European Heart Journal Dialogue of this afternoon. I am Giovanna Liuzzo. I am an associate editor of the weekly journal Scan, and I will moderate this dialogue together with Carlo Patrono, that is the deputy editor of this section. It is for me really a great honor, a pleasure to have with us this afternoon three top scientists into a very important field. That is the field of atherosclerosis. Starting from their discoveries and their studies and their works, we have changed our understanding of atherosclerosis. And this afternoon with us we have Professor Ziad Mallat, that will tell us something about the opportunity to modulate the immune response in order to reduce the atherosclerotic background and the residual risk in a patient with atherosclerotic cardiovascular disease. And he will be our special guest. And then together with him, we have Professor Libby and Professor Ridker that will act as a discussant, giving us a lot of information regarding the opportunity to reduce the inflammation using anti-inflammatory strategies with anti-cytokines, or maybe even addressing the NALP3 receptor. So it's a great pleasure to give a brief introduction of our three guests, even if I'm sure that they don't need to be to have an introduction. Professor Mallat is currently professor at British Heart Foundation at the University of Cambridge. His work actually have introduced the ather-protective role of regulatory T cells and also of subsets of B cells. And his basic research is complemented by proof-of-concept clinical trials in patients with atherosclerotic cardiovascular diseases. Recently, he was elected a member of the Academy of the Medical Science, and he made a huge program that was to create a Google map of human atherosclerosis. Today he's with us to speak about the Ivory trial. We will learn in a few minutes more about this. And then we have Professor Paul Ridker, that serves as the Eugene Brownwell Professor of Medicine at the Harvard Medical School and is the director of the Center for Cardiovascular Disease Prevention at the Brigham and Women's Hospital in Boston. And we know that Paul did a huge, important trials in general in cardiology, but in particular, he is the leader of the CANTOS trial, that was the proof of concept trial in anti-inflammatory treatment of coronary artery disease. And now he is the leader of Zeus and Artemis trial that are trying to investigate the use of an anti-IL-6 in the same field. And then we have Peter Libby. Peter, what say about Libby? We think differently about atherosclerosis after all the work that Peter have done in this field. He is professor of medicine at Harvard Medical School. He is also a chief cardiologist at the Brigham and Women's Hospital in Boston. Actually, Boston is a very lucky place to have these two top scientists together. He's globally renowned for his pioneering research, establishing that inflammation drives atherosclerosis. So it's not just a matter of lipids, it's a matter of lipids and inflammation together. And now let's start immediately, because I'm sure that we will have a lot of fun during this dialogue and a lot of information, a lot of questions. And I would like to start with Ziad, with Professor Mallat, asking Ziad to summarize for us the hypothesis, the idea that is behind the ivory trial. Please, Ziad. You should unmute. Amelia, could you please unmute Ziad?
Great, now it's work. Yes. Okay, great. Thanks very much. Thanks very much, Giovanna, and really it's an honor to join you and Professor Patrono for this dialogue. And I said it's a privilege for me to share this platform with Professors Peter, Libby, and Paul Ridker. So I guess as you said, I'm invited here to talk about the ivory trial, but let me give you an introduction and
we seem to be having some technical problems. I don't hear Ziad anymore. Giovanna, do you? Is it
I don't know. No, I cannot listen.
Ziad, we don't hear you.
He seems to have been frozen.
The nice thing to be online directly. So maybe in the meantime that we recover the Ziad connection, maybe we can ask to Peter to say something about atherosclerosis, inflammation, immunity. As Peter, let's say that you are not for age, but you are really maybe the father of all this, story. And then you have other colleagues, other scientists going ahead very well in this path that you have designed as a pioneer. Please, Peter.
Well, first of all, Giovanna, the New England Journal paper that you first authored with Attilio Masari was one that really changed the course of this whole field when you were focusing on C-reactive proteins. So you and the Rome group certainly deserve a lot of credit for this. And I have a long-time partnership with Professor Göran Hansson in Stockholm now. So we work together in the time when no one believed in inflammation, but the tide has definitely turned. And so I think you really capsuled it by saying that there's not a competition between traditional risk factors, such as lipids, and the inflammation hypothesis. We view inflammation as a series of biological pathways which can transduce some of the effects of the traditional risk factors, such as hypertension and various forms of dyslipidemia, into altered behavior of the artery wall that gives rise to the disease and its complications. And I think that what we're doing now is trying to harness that recognition therapeutically. And that's where the work that Ziad has done is key, because we're all searching for the sweet spot, which will mute inflammation, the pathological parts of inflammation, but maintain host defenses against infection and tumor surveillance. And so that's why we really welcome things like the ivory trial, which are designed to manipulate regulatory T cells, which can have anti-inflammatory effects, and see if we can mute the disease without impairing host defenses. So the work that Ziad, I hope, will be able to talk about in just a moment.
I'm here again.
He's again.
I'm really sorry. I'm at the French Society of Atherosclerosis meeting and joining from a hotel room. So it's Let's see. So thanks very much, Peter. I heard that you were presenting the inflammatory hypothesis, etc. So I will go forward very quickly now to say that what we are doing and what we thought to do in the lab, in fact, is that in two things that are different that we are doing that have not been done until now is instead of targeting the innate immune system, we are targeting the adaptive immune system. And instead of targeting pro-inflammatory mediators and pathways, our aim is to target and promote and modulate immunity in order to, the endogenous regulatory responses. And this is how we came to Tregs. And as you know, Tregs are, I should say, the primary mediators of immune tolerance. They suppress, they regulate and suppress pro-inflammatory responses by several means, producing anti-inflammatory cytokines like IL-10, TGF-beta, but many other means. And they are important also in tissue homeostasis. And I think that we will have the time to talk about this. And there was our group and others have provided preclinical data on the importance of these regulatory T cells in suppressing inflammation and protecting against atherosclerotic lesion development, but also others have shown their roles in post-myocardial infarction remodeling. And in fact, work from Giovanna present here in patients with non-ST elevation MI has shown that these Tregs at the acute phase of myocardial infarction are reduced both in numbers and in function. And in fact, we thought that this could be, promoting regulatory endogenous immunity could be an interesting way forward. And the most straightforward and feasible way immediately to do it was to harness interleukin-2 for this aim. In fact, interleukin-2 is marketed at very high doses for the treatment of renal cancer, and it activates T effector T cells. However, what is really interesting for IL-2 is that comes from the Tregs themselves. In fact, the Tregs express what we call the trimeric IL-2 receptor, which has a very high affinity to IL-2. So with very low doses of interleukin-2, you can activate the Tregs and without touching the effector T cells. So we wanted to harness this mechanisms, and then we designed a series of double-blind, placebo-controlled, randomized clinical trials. And I would like here to thank my collaborators, Joseph Sherian, all the Lilacs and Ivory team, Joseph Sherian, James Rod, Steve Hull, and of course Tian Zhao and Rochelle Sararanjan. So these trials were designed first, the Lilacs trial, which was published before, in order to establish the safety and biological efficacy of different doses of IL-2, and then select the best dose to go forward for a phase 2b clinical trial. So the Lilacs trials has established the dose that is required for going for Ivory. And this dose was selected on the basis of extensive mechanistic information. So once we have defined this dose, we designed a trial to go the next phase before going to a phase 3 clinical outcome trial. And these are trials in which you should use what we call a surrogate endpoint that is validated enough, a surrogate endpoint of cardiovascular events. And we thought that FDG PET-CT detecting signs of arterial inflammation was a surrogate endpoint that had the most validated evidence in the literature. And so in Ivory, what we did is that based on the hypothesis that in acute coronary syndromes, there is a reduction in both the numbers and the functions of Tregs, we wanted to take and test this hypothesis in this setting. So the study was designed for patients with acute coronary syndromes, whether ST elevation MI or non-ST elevation MI, and residual inflammation as measured by high sensitivity CRP, and we can discuss about this later. And the idea here again, was to look at the impact of IL-2, low-dose interleukin-2 versus placebo on the endpoint of vascular inflammation as measured by FDG PET-CT. So these individuals, these patients were recruited at the acute phase of MI, and they were randomized to placebo and low-dose interleukin-2 treatment. And the IL-2 treatment consisted on an induction phase of 5 consecutive days of subcutaneous injections, then a maintenance phase of weekly injections with IL-2 versus placebo until a total of 8 weeks. And the patients had FDG PET-CT at baseline and at follow-up. And we can discuss about the timing of the treatment. So the primary endpoint was set up as a difference between group difference in vascular inflammation at the end of the treatment period. We recruited around 69 patients were recruited into the trial and randomized to placebo versus IL-2 with almost equal numbers in each group. The median age was, I think, about 55 years, and most of the patients were men and white men. So we can discuss it. What is important, and I should really insist on this, is that these patients were on optimal medical therapy. So almost 100% of them were on dual antiplatelet therapy, high-dose statins, and anti-hypertensive, but also angiotensin, renin-angiotensin inhibition. So in summary, what we saw is that low-dose IL-2 did what we expected it to do in terms of changing Tregs numbers without changing effector T cells. So there was a sustained increase in Tregs versus T effectors in these patients. The T effectors didn't move. And in terms of primary endpoint of difference of FDG PET-CT signal at the end of treatment between low-dose interleukin-2 and placebo, that was significant. And we saw an approximately 8% reduction difference in this endpoint between low-dose interleukin-2 and placebo, as expected by the sample size calculation. And in fact, we designed the study for this amount of reduction because based on what high-dose statins have shown in terms of reduction of inflammation in comparison with usual moderate intensity statin. And of course, we had additional secondary endpoint of inflammation in the most active segment and the most disease segments, and all of these parameters and secondary endpoints were significantly reduced with low-dose interleukin-2 in comparison with placebo. Now, when it comes to safety, the adverse event rates, let's say, were similarly distributed between the two groups, with, of course, and this was expected, much more administration site reaction in the IL-2 group in comparison with the placebo, and these were mild reactions and transient reactions. In terms of infection susceptibility, we didn't see any difference between infections between the two groups. And in terms of, the study was, of course, not designed to look at clinical outcomes, but we had, at the time of publication, we had completed 2 years of follow-up, and we have seen 4 major adverse cardiovascular events occurring in 3 patients, and all these events were in the placebo group. So to summarize this, we think that this is an important step forward in our testing of the hypothesis of modulation of endogenous regulatory responses to limit inflammation and cardiovascular events. I think we are transitioning from, let's say, innate cytokine inhibition and single cytokine inhibition with IL-1 beta and IL-6 to more adaptive immune modulation, which in my opinion represents quite a shift towards potentially, more effective and safer therapies. And that the Treg discovery of the Treg mediated tolerance has been recognized with the Nobel Prize of Medicine or Physiology of Medicine in 2025. And we believe that it is time to really fully translate the science into the cardiovascular arena. So I really look forward to our discussion about potential complementary anti-inflammatory approaches in our patients.
Perfect. So let's go ahead in deeper in this dialogue. Carlo, do you like to make a question to our guest or to the discussant?
Maybe I'll ask Ziad about the dose finding, because the previous dose finding studies that you mentioned used as their primary endpoint circulating Treg expansion and not vascular imaging. Now, this indicates that the optimal dosing strategy for reduction of vascular inflammation remains to be defined, since you use only a single dose in in your ivory trial. And I'm wondering whether, in light of the rather modest effects of the dose used in the ivory phase 2 study on vascular inflammation, whether you are considering repeating a dose-finding study using vascular inflammation rather than Treg expansion as the primary endpoint before moving to phase 3 clinical endpoint trial.
Yeah, this is a very important point. Carlo, when we selected the dose, in fact, we really selected the dose based on extensive single-cell RNA sequencing studies in blood PBMCs, in order to look at what are the signaling pathways that are activated in the different immune cell subtypes. And this was really the basis of our selection of the 1.5 million dose, because it was highly selective for Tregs. So we didn't want another. So I agree with you that we tested only 2 doses in patients with acute coronary syndromes, 1.5 and 2.5. So the 1.5 was very interesting in terms of its selectivity for Tregs. The 2.5 was still activating, of course, in Tregs, but there was some spillover towards the other, to activating pathways and the other effector T cells, and this is why we didn't want to test it. Now, the question is that whether you go to 2 million units, it's what is the right dose here? And you're right that these were selected not based on how vascular inflammation is being reduced, but how it's modulating the immune system. Now we have additional studies that are ongoing in order to see
the relationship between the two. I mean, do we know the relationship between Treg expansion and reduction of vascular inflammation?
So what I can tell you is that this is an active area of research now in the lab, working on the ivory trial. So if you look at just the number of Tregs, there is a very limited relationship between the increase in Tregs and the decrease in vascular inflammation. There is something that approaches significance, but in fact, we think that the number alone is not indicative. So this is why we are doing currently single-cell sequencing on all these patients. And in fact, we started by identifying groups of high responders versus low responders, and do these single sequencing studies in order to get more biological information about what's happening in the different cell types in these patients. And I can tell you that it will be interesting, because we have some interesting pilot data about this, but this will come later.
Thank you, Ziad. I'll leave the floor to our invited discussants. So Peter or Paul.
So I had the word early, so let's go to Paul, and I'd love to contribute later.
Well, sure. So I have a couple quick comments. First of all, Ziad, congratulations. I think that anyone involved in trying to take a molecular concept into clinical practice has to have tremendous tenacity. And I think that is a descriptive term for any scientist who's been successful. So first of all, very congratulations for getting this far. I think it's terrific you guys have been able to do this. I want to emphasize a couple things right up front that may not be crystal clear to everybody. To date, almost all the work done by investigators globally has really been on the innate immune side, right? It's been IL-1 inhibition, it's been IL-6 inhibition. We can put colchicine somewhere in that category. I think it's been known for a long time, work by yourself, by others. The adaptive immune system is another piece of this that's crucially important. We all understand that the precise definitions of what's innate and adaptive have modified over the years. But I think the Treg biology is exquisite, and the idea of using this interesting drug, aldesleukin, for this purpose is very creative. Aldesleukin, for those of you who don't use it, at much higher doses, our oncology colleagues use this for like renal cell carcinoma, I think for melanoma, where it has some efficacy, but also some adverse effects. You're doing something else creative, Ziad, which is this low dose notion is really important. I think we've learned that on the innate immune side. You really you want to modify this inflammatory response. You don't want to negate it. And I think the low dose approach makes a lot of sense. you also have my sympathy. I trying to design exploratory clinical trials with a surrogate endpoint. It's so hard. You'll get critics who say this is a good endpoint, it's a bad endpoint. I would recommend ignoring them and believing that your data are moving in the right direction and keep on moving forward. It's just very hard to figure out what short of a major outcome trial is going to matter clinically, but we have to find surrogates that actually can allow us to drive things forward. And then actually, the other thing, I particularly was reading your paper for safety. I think the fact that at least in these 30-odd patients who received active therapy compared to placebo, not seeing a significant difference is important. It's something that we have to figure out here. I suspect all of us on this panel, and certainly I know Peter and I would probably argue that, look, the future of atherosclerosis therapy is going to be some combination of very aggressive lipid lowering combined with some combination of unique anti-inflammatory therapy. How we get there is the challenge, and I think this is a creative, novel way of thinking about where we might go. So I was intrigued, and I read the paper very carefully, and I really enjoyed seeing it.
So if I can ask something to all of you, what do you see as the best strategy? A strategy that goes against the innate immune system, as we have done still now, starting from the inflammasome, NALP3, then pathway. And if the answer is yes, at what point of the pathway you will target best? At the level of the IL-1, IL-6 cytokines upfront, or you will best try to develop right now with the information that right now we have, trying to better develop a positive, a protective immune response. Paul, first because you are so involved in the other pathway, in the attempt, to target the innate immune system.
Well, sure, although I'm quite interested in what Peter has to say as well. So the reality of this is that because of work done by Charles Giovanna and Peter a long time ago, when the IL-1 pathway was sort of figured out, Peter and I had the opportunity to coerce Novartis to allow us to do what is CANTOS, and it's just a wonderful experience. So we have proof of principle in that NLRP3, IL-1, IL-6 pathway. Many people, including us, have generated some evidence that maybe the magnitude of IL-6 inhibition is a driver of that. We also know that the IL-18 signal is real. So a very good argument can be made, as you're well aware, to go downstream to IL-6, and we have 3 different IL-6 ligand inhibitors that are in late-stage development. That's great. Going upstream to NLRP3 makes a lot of sense to many of us in this arena as well. It's a bit of a wild card. If we pick up the IL-18 signal, would that be helpful? Which part of the NLRP3 inflammasome do we want to target are all big questions. But I think what I'm excited about the work you just heard about from Ziad is that I don't think that's the only pathway. It happens to be our current proven pathway. But from a biologic perspective, immunity is a very complex issue, and finding how different inhibition of different pieces might help us with atherosclerosis is what we're trying to do. And clearly, we know from other therapies, there's very specific issues that work better or worse for inflammatory bowel disease or for Crohn's disease or for psoriasis. And I think we're just at the beginning of figuring out where do we target the immune system for atherosclerosis. But again, I mean, Peter's been thinking about this from a more bench perspective than I have for a long time. I know we're both involved in drug development across the spectrum.
Peter?
Yeah, well, one thing that clinical trials instill is humility, because you can have all of the preclinical and all of the phase 1, phase 2 data and still be surprised. So Paul conceived, got funding for, and executed the CERT trial, cardiovascular inflammation reduction trial. And we know that low-dose methotrexate, which was the intervention that was studied there, has revolutionized the treatment of rheumatoid arthritis. And we had every expectation that we were going to have a winner. And unfortunately, it turned out in the population studied to be a null. So we have to try many shots on goal. And just when Ziad rejoined us, I was saying that we have to welcome all different types of intervention because we need to find that sweet spot, and we can't predict. So it's the large-scale clinical trials that will give us the final answer, and we need to launch many ships in order to have some come back to port. So that's one of the reasons that we're so enthusiastic about Ziad's efforts, courage, tenacity to bring this on board. Let me just go back to something that Paul mentioned, because not all of the audience may know the history of IL-1 therapy, IL-2 therapy, I'm sorry, when it was T-cell growth factor, actually. So Steve Rosenberg was a surgeon at the National Cancer Institute. And Paul, I think you were around at that time.
Was.
And he was using high-dose IL-2 in order to try to activate the adaptive immune response in an anti-tumor. And the limiting toxicity was actually a capillary leak. And Ziad, I'm sure that you are aware of the paper that I wrote in JI, in Journal of Immunology, in 1988, about how IL-2 can induce NK adhesion to endothelial cells and can injure the endothelial cells. So we were thinking about high dose and trying to explain the capillary leak syndrome by endothelial injury. And one of the things that Steve discovered, and you can tell us the answer with your flow and with your single cell, is whether NK cells go down, which would be a very, if they don't, it would be a very good indication of the selectivity of the low dose versus the high dose, because I think Steve Rosenberg called attention to a drop in NK cells, natural killer cells. So in your paper, the Nature Medicine paper, you have a number of different cell types enumerated, but I wonder cells with markers of NK, if they were stable, that would be very reassuring about your selectivity argument.
Yeah, can you hear me well?
Yeah.
Yes.
Yeah. So thanks, Peter. Yeah, I mean, your comment about the NK is really well taken. You know, we are very interested in this. So we have a signature. We have an NK signature. What is really interesting is that the NK that are in patients under IL-2 treatment are very different from the NK under placebo, and in fact, they switch towards a non-cytotoxic phenotype, which is a reduction in CD16, etc. So we are very interested in this, but there is definitely an IL-2 signature that we can see that is very different from what you see from the high dose interleukin-2. In terms of modulation, you know, I think that what kind of anti-inflammatory therapies we should use. I think that one thing is, of course, to look at the pathways that have been shown to be causally related to cardiovascular disease, and this is why IL-6 is very interesting, and we are looking forward to see what's happening. And what is interesting with Tregs and IL-2 is that, you know, a posteriori, we found out, you know, I mean, it's not me, it's Mike Inouye and Adam Butterworth in Cambridge, who published, you know, when they were analyzing the multi-omic biological pathways, you know, they were analyzing biological pathways that could be causally related, you know, genetically determined and causally related to cardiovascular disease. And the IL-2 STAT pathway is there. So it is causally related, you know, a protective IL-2 signaling is causally related to a protection against cardiovascular disease, which is really amazing. And the other thing with Tregs is that you can regulate any type of inflammation, not only the inflammation that is mediated by IL-1, IL-6, but also the inflammation that is mediated by type 1 interferon, by type 2 interferon, etc. So it is any kind of inflammation can be regulated by Tregs, by stimulating Tregs. And even more, I would say, and I always say it, beyond inflammation, Tregs are produced growth factors. They are very important in tissue homeostasis, and they are important in tissue repair and healing. So this is why we see that this pathway should be promoted. Maybe now with low dose interleukin-2, but later with other drugs that promote these Tregs in the tissues.
Okay, great discussion still now. I see in the audience Christopher Binder. I cannot avoid to bring you in the discussion, Christopher, because we had a very nice discussion a few months ago in Milan about how to, address inflammation and immunity in atherosclerosis, and you showed wonderful data about B cells. So please, Christopher, tell us something about this.
Yeah, as Ziad said, I mean, I think this is obviously the other part of adaptive immunity. But Paul rightfully pointed out that the line between innate and adaptive immunity is sort of a gray one. And the one we're working on is sort of something in between of these IgM antibodies, which similarly to regulatory T cells also seem to play an important homeostatic functions, like protecting from inflammation, promoting the clearance of damaged material. And therefore, one strategy would be, of course, also to enhance these homeostatic functions that these B1 cells and the IgM antibodies they secrete mediate. So I think that is an attractive approach. And Ziad and I, we wrote a review a few years ago where we said there's two ways to address inflammation. On one hand, simply inhibit pro-inflammatory mediators, which can be cytokines, or we could find more specific ones like oxidized lipids that we can simply try to neutralize, or we can enhance some of these endogenous protective functions. And I think that is a very attractive approach, as Peter pointed out, because that would allow us to maybe enhance these properties without hampering important host defense functions that you would do if you sort of don't find the sweet spot by inhibiting pro-inflammatory mediators. So therefore, I think it's sort of the other side of the coin of adaptive, or the gray zone between adaptive and innate immunity that would complement regulatory T cells. And I think with that, if we keep that in mind, I think that will allow us to really approach anti-inflammatory strategies in many different ways and find maybe the adequate one. And on top of what I would like to add is, I think what we would need to identify, of course, those that would benefit the most of it. And in this case, those patients maybe that have an impairment in these homeostatic responses, where we can see by enhancing them, bringing them back into balance, maybe this would allow us to really target this appropriately. But of course, there's a lot of work to do. I think that's still ahead of us.
Christoph, since you brought up B cells, maybe Ziad could tell us about READA2-MI, which is a study that's underway.
Yeah, I would first start by what we did on B cells in the Ivory trial. In fact, in the LILAC trial, in the low dose interleukin-2 trials that we did. So in LILACs, we are doing we looked at what is the impact of low dose interleukin-2 on the immune landscape beyond T cells and Tregs. And in fact, of doing detailed mechanistic analyses, we identified that low dose patients treated with low dose interleukin-2, their B cells are promoted towards plasmablast-like B regulatory cells. So the B regs, now not the T regs, that produce interleukin-10, which we know, my group and others confirmed this later, is a major anti-inflammatory mediator, but is a major atheroprotective cytokines in this. So on top of promoting Tregs, we have B regs that are being promoted also by low dose interleukin-2, which feed forward into the potential benefits that this therapy can bring. And as Peter was mentioning, is that we worked on other types of B cells in atherosclerosis and myocardial infarction. And these mature B cells that are mostly coming from the follicular B cell subtypes, we showed that they are important in terms of promoting atherogenesis in mice and are involved in adverse remodeling of the heart post-myocardial infarction. And this led us to propose another type of therapy, which is depleting the subsets of B cells at the acute phase of MI. And there is a current, after a first trial of safety also and dose finding, that we published in Cardiovascular Research about different doses of rituximab, which is an anti-CD20 monoclonal antibody. We determined, we selected doses to go forward for a phase 2 trial, and which is the RETIME-I2 trial, which is currently ongoing around Europe and funded by the European Commission. And the aim is to, we are randomizing patients to rituximab versus placebo and looking at the primary endpoint, which is left ventricular ejection fraction at 6 months. And in fact, there is a sub-study looking at vascular inflammation because, as the Harvard group showed that with Phil Swirsky and Matthias Narendorf and the help of Peter, showed that post-MI, there is an acceleration of atherosclerosis. And in fact, an Australian group showed that part of this acceleration is mediated through B cells. So there is a sub-study in RETIME-I to look at vascular inflammation in response to rituximab.
Great. I am a cardiologist, as all of you. So let's say some words also for our colleagues and for ourselves. First, how important is to target inflammation in our patient with atherosclerotic cardiovascular disease? Maybe Paul or Peter would like to take care of this question. And then it's possible, do you think, right now, with the knowledge that we have, to be more, really precise, targeting really in each patient what the patient needs to improve the outcome, or we should still do a lot of work in this field. I would like to remember that we started with the inflammatory hypothesis at least 30 years ago, 30 years ago.
Giovanna, I'll jump in here from the clinical side. So we all know that LDL cholesterol is our fundamental modifiable risk factor, as well as blood pressure control. So all our patients need to have very good blood pressure control and extremely good lipid control. But the reality is, and it goes back again, exactly as you say, 30, 35 years, to understanding that a lot of our patients have perfectly good blood pressure, perfectly good lipids, and are having heart attacks and strokes. And we have to recognize there's more to this than only these two fundamentally proven factors. The data we presented, others presented, replicated now around the globe, multiple different ways, consistently tell us that when you're on a statin, measures of inflammation, whether it's CRP or IL-6, tell us at least as much as LDL cholesterol. In most of our papers, it actually tells you more in terms of what the poor outcomes are going to be. Turned out to be the same in primary prevention. We can measure an hsCRP 30 years ago and predict long-term cardiac risk probably better than LDL cholesterol does. We all want to lower LDL. It's our fundamental issue. But all the clinical trials we're talking about, and Ziad will have to face this as well, whenever this ever gets to a larger outcome setting, it's going to have to be on top of very aggressive quality of care. So all the IL-6 trials that will be coming out, the first of which will be later this year, I'm going to hope the LDLs are in the 60s and 70s, because that's what they should be. Our guidelines internationally, as you know as well as I, are moving the LDL even lower, and that's fine. The trick is the relative risk reductions for dropping LDL are real, but the absolute risk reductions are getting very, very small. I'm much more optimistic, I think, on the inflammation side, on top of aggressive lipid lowering. I hope we see relative risk reductions and absolute risk reductions that matter to us clinically. But again, as I said earlier, I'm in the camp that really believes these two things are fundamental to the development of the disease, to the likelihood of a plaque to rupture, and that we need to hit both of them if we're going to really change fundamentally outcomes for our patients. Giovanna, as you and I have talked about, from a clinician's perspective, as you and I wrote about, doctors will not treat what they don't measure. So we've been working hard to try to get universal screening guidelines for CRP in place, the same way you have such guidelines for LDL and blood pressure, and now for Lp(a), because on the clinical side, most people I see on this call are pretty eminent scientists and very thoughtful people about biology. Our clinical colleagues need to be brought along, and I think the way to do that is to get them to have screening for CRP, so that at least they're thinking about the fact, oh, I'm doing all the things I thought were correct, but look at that, the CRP remains high. Maybe I need to pay attention to this inflammation, and maybe we need to intervene upon it. I think those are challenging tasks, but I think we're getting there. And actually, I have to give the European Heart Journal an enormous amount of credit. I think the European Heart Journal, more than any other journal, has really promoted this idea. And I'm almost embarrassed to admit, I think the European guidelines will probably beat the American guidelines to getting this right. So we'll see where we get to.
Peter? Oh, Carlo. Carlo, maybe.
Yeah, Carlo has his hand up. I think he's been very patient. He's
No,
moderator-in-chief.
Thank you. I'd like to continue with Paul because he's heading a very important trial, Zeus, which not only is targeting one particular cytokine that we have been discussing, IL-6, but I think it's somewhat turning from a previous phase in which we have used existing drugs that had been developed for treating other inflammatory conditions like canakinumab, methotrexate, or colchicine. And we are now moving into a phase in which one big pharma company is developing a new drug, a human monoclonal antibody against IL-6 ligand with a cardiovascular indication in mind. And I was wondering, Paul, sorry, whether you would like to say something about the design of this innovative trial, how it differs from the previous anti-inflammatory drug trials that have been published so far.
Sure. So, Carlo, thank you very much for the kind words, as well as for opening this up a little bit wider. So, yeah, there actually are 3 IL-6 ligand inhibitors now that are in development. The first is ziltivekimab, which was actually developed by colleagues of ours in Waltham, Massachusetts, under a small company called Corvidia, picked up by Novo Nordisk, and working with Novo Nordisk over the past several years now, we've had this phenomenal opportunity to really design 3 large cardiovascular outcome trials. The first one, which will be reported out later this year, we're in the closeout phase right now, is Zeus, which was the trial designed for patients with chronic kidney disease, known atherosclerosis, and what we call residual inflammatory risk, an hs-CRP greater than 2 milligrams per liter. One of the reasons that was the pivotal trial was, for example, we don't want to give colchicine to patients with chronic kidney disease. That's a relative contraindication. And because patients with chronic kidney disease, as all the clinical community knows, have a very high cardiovascular risk, enormous unmet clinical need, and a very high rate of decline. Zeus actually has 2 primary endpoints. One is the cardiovascular outcome, and one is a change in renal function. That's based partly on work by colleagues like Kathy Tuttle, who's shown that NLRP3 IL-6 function in the kidney is also very important. That trial will be out later this year. We also launched something called Hermes, which was a HFpEF trial, mid-range HFpEF trial. That's much more controversial, really. It's really going into a novel area where the ideas of, can this anti-inflammatory approach affect fibrosis? Is it too late? Is it too early? That one has tremendous equipoise. And the third, Peter's going to laugh. We originally had designed something called CANTOS 2 back in the day when we were working with canakinumab. CANTOS 2 was an acute coronary ischemia trial that has reborn itself in what's called Artemis, which is the ziltivekimab version of that, and that's also almost fully enrolled. So we're going to have a lot of clinical trial data. But Carlo, you know, it's interesting. While these are novel IL-6 drugs for atherosclerosis, IL-6 inhibition has been around for 20 years and been used, at least receptor antagonists largely used by our rheumatoid arthritis colleagues and our GI colleagues who have managed the safety quite well. So I'm optimistic on the safety side. CSL Behring has a drug called clazakizumab that they're taking into actual dialysis patients at extremely high risk of atherosclerosis. And Novartis picked up the Tourmaline Bio drug, and they're trying to figure out what to do with that as we move forward. So we're very excited about that. But, you know, I think a good rationale can also be made, Carlo. Let's keep our fingers crossed. Certainly I am nervous about it. We'll see about Zeus. I'm blinded. The company's still blinded. We'll see where this goes. But if that's positive, I think it's going to open up the floodgates because now we'd have between CANTOS and ZEUS 2 randomized, double-blind, placebo-controlled, targeted therapies in that pathway. It'll open up development for NLRP3s, it'll open development for IL-18s, it'll open up development for these alternative pathways like Ziad is talking about. So we'll have to see what happens, but we're very excited about it.
Well, as you probably know, I'm quite interested at this time of my professional life in common mechanisms of disease, and inflammation is certainly one of them. Platelet activation is another. And I'm intrigued about the common mechanisms of disease across cardiovascular disease and cancer. And your observation in CANTOS that you saw a decreased rate of lung cancer makes me wonder whether you included pre-specified cancer outcomes in ZEUS.
Yes, we have, and in particular, because the signal in CANTOS was almost uniquely non-small cell lung cancer, which, by the way, made a lot of sense given these proportion of smoking going on. Yes, so all non-small lung cancers are being adjudicated in general across the ziltivekimab platform. We were a little lucky in CANTOS in the sense that, as Peter remembers, we had 3 different doses. And so we got a dose response effect on the lung cancer that was quite intriguing, and I think really biologically important for trying to understand these concepts. But again, Carlo, as you know as well as I, this idea of commonalities across biology and the commonalities that atherosclerosis may share with cancer in terms of endothelial function, how cells metastasize across the vascular endothelium, very similar to how macrophages have to adhere and attach to cause atherosclerosis. So all these things really are common. And all the interest in clonal hematopoiesis. At the end of the day, we're talking about a bone marrow function, an acquired immune problem that leads both to cancer and to atherosclerosis. So I too sit in that sort of systems biology way of thinking. In fact, at the Harvard Medical School, the part of the school curriculum I'm most interested in is teaching fibrosis, inflammation, senescence. Trying to teach organ systems still seems kind of old-fashioned to me. But anyway, very exciting year.
Thank you. Back to Peter.
Yeah, so could I ask Ziad, what's the relationship in your experimental work between the blood Tregs, which is what you measured, and what's going on inside the plaque?
Yeah, Peter, this is really the most next important questions that we are trying to tackle now. So, of course, all these studies, we didn't have information from the tissues. And we think that information from the tissues will be very important. And with Tian Zhao in Cambridge, we completed now the ELLIPSE study. What we did is that we randomized patients who were admitted for stroke or were having a scheduled carotid endarterectomy within 14 days. And we randomized them to low-dose interleukin-2 versus standard of care. And we obtained, at baseline and post-treatment, their blood for single-cell sequencing, but also we obtained their carotid endarterectomy specimens for single-cell sequencing. And we are now doing the data. I cannot disclose the data, but this is how we will be able to see how low-dose interleukin-2, even in the short-term period, after short-term period, how does it affect the immune landscape within the lesions themselves in the diseased tissue?
That's great. It's wonderful you're doing that. And I'm glad that people are calling a gray zone between adaptive and innate immunity because the crosstalk is enormous. In fact, the effectors of the regulatory T cells are cytokines, right? And the activators of many lymphocytes are cytokines. So it's really hard to draw a very sharp distinction between cytokines and cellular immunity because they're inextricably linked.
Yeah, I totally agree. I mean, and this with the studies, with this ELLIPSE study, I think that what we will be able to see are relatively acute changes, in Tregs, whether the Tregs are proliferating, whether they're accumulating, where they are accumulating, how they are impacting the immune landscape, but also potentially, the stromal cells, not only the T cells, not only the macrophages, but potentially the inflammatory activation of the stromal cells, endothelial cells, and smooth muscle cells that contribute to the process.
Yeah, talking about commonality, which several people have mentioned, the tumor microenvironment and the plaque microenvironment have enormous similarities.
So in fact, of tumors, we heard now here in the meeting, I am from Florent Genoux talking about the role of macrophages in cancer progression and tumor progression. And inflammation, mostly innate immune inflammation is very, is known to promote cancer progression. And as has been shown with the CANTOS trial and others, that blocking this innate immune inflammation may have an impact on tumor progression potentially. But again, I think what we are doing in terms of regulation of endogenous the immune system. We talked about the Treg effects on T cells, on B cells, but there is a strong impact on macrophages too, and changing the activation status and the phenotype of the macrophages will be also important to look at in these studies.
Ziad, you have to put platelets also into the equation because there is recent evidence that thromboxane A2 released by activated platelets gives a negative signal to T cells reacting against cancer cells, which may be a molecular explanation for the anti-cancer effect of low-dose aspirin.
So Carlo, I totally agree, with analysis of some of the data we have. We have some p-selectin related pathways that could potentially be interesting. So stay tuned.
Okay. Carlo, I'm smiling because it was my work with Charlie Hennekins 35 years ago. The only reason we went down this pathway was because of the aspirin data based on your work that Charlie had done the physician's health study. Then we made this crazy observation that somehow or another aspirin modified the relationship of CRP to outcomes. And of course, we've attributed that to some combination of antiplatelet and anti-inflammatory effects. And that was sort of, at least for my group, the beginning of this whole process. So it is funny how this does come full circle, because I think all these components of what causes acute thrombosis are going to really matter here. And how we find the right dose of different drugs targeting different pieces of this. That's the clinical challenge.
Particularly since the primary endpoint of all these trials is atherothrombotic in nature.
Right.
Okay, back to Giovanna.
So I think that we have done a good job in 1 hour, very intense of discussion and a lot of science. And I see the audience was very high number of presence, but I think they were, very, very, particularly shiny to make questions to a so important scientist. So I don't see many questions into our chat. And this is why maybe we can just make a final statement. Carlo, if you like to make the final statement or a final, round of very quick questions, because we have finished our time. 1 hour is gone away.
Sure. I'd like to finish by simply congratulating 3 eminent scientists who have contributed a lot to the basic understanding as well as the clinical translation of different concepts underlying the development of atherosclerosis and its atherothrombotic complications. This is a sign of persistence and determination, which is admirable, but it's also the result of respecting some basic principles on which science should be based, which is a fair assessment of your colleagues' grant applications, that is the peer review system, as well as international collaboration. We would not be here if having common roots and experiences and common soil, if not because of international collaboration. At a time when the peer review system for funding good science is put into question and international collaboration is put into question, I think we should stand and defend these principles. So thank you very much for having accepted our invitation to join us in this interesting dialogue. Thank you, Giovanna. Thank you, all the participants and the people who will see this on X or whatever other media they will choose for listening to us.
Thank you very much, Carlo and Giovanna, Peter, Paul, and we will surely need these international collaborations for the phase 3 clinical trials for low-dose interleukin-2.
Absolutely. Thank you, Ziad.
It was a pleasure. Thank you very much.